Dr. Tenon, with that introduction, I hand it to you for today's presentation. Thank you.
Thank you so much. And thanks everyone for joining today. It's my pleasure to be with you. As Stefan said, I'm going to be presenting on psychiatric issues following stroke in young adults. So stroke in the young is usually defined as ages 18 to 50 or 18 to 55. In my clinic, I mostly see patients above the age of late 20s or 30, so that's where my focus will be today. And thank you for that introduction. I did want to mention a bit about me. So I developed an interest in medical psychiatry early on, and then followed that through with my fellowship, where I did a lot of both inpatient and outpatient medical psychiatry and consults, and also spent time with the stroke neurology team there. So when I returned to Toronto and went on staff at Sunnybrook, it's an academic center that also has a stroke center. So I was able to service that population and start a stroke-related psychiatry service, which started inpatient and outpatient, but now it's outpatient. So I will be sharing some patient snapshots and cases from my clinic today, and I hope that will help illustrate some of the important issues and challenges that this population faces. I just need to advance. Oh, there you go. Okay, so our learning objectives today are to understand the impacts that stroke can have on the mental health of adult patients. We're going to identify key psychiatric issues that can emerge post-stroke, including depression, as well as anxiety. And I'm going to touch upon a few other things to just be aware of, but the focus of today's presentation is mostly going to be on post-stroke depression. And we're also going to discuss treatment strategies that will hopefully promote optimal mental health with people who have had experienced stroke. And here's what we're going to do, a quick overview. So we'll go over stroke in the young facts. We'll discuss why post-stroke depression is important. I'll give you some patient snapshots. We're going to talk about a case in post-stroke depression that will include treatment considerations, and we'll do a shorter case for anxiety. And then just as I said, touch upon a few other neuropsychiatric issues to consider when you're thinking about treating this population. So the definition of stroke is good to just review. It's a rapidly developing episode, neurological dysfunction caused by an infarction. There's objective evidence of ischemic injury. It's not a TIA, so symptoms persist over 24 hours, and other etiologies have been excluded. We know that approximately 85% of strokes are ischemic, where the blood supply is interrupted to the brain and it causes cell death, and 15% is hemorrhagic, where there's bleeding in the brain. And there's impact of stroke in Canada. There's over 60,000 strokes per year. Over 400,000 people live with the effects of their stroke long term. The incidence is expected to go over time, and approximately 15% occur in the under 55 age group. We are seeing more stroke in young adults over time, and this slide illustrates what we've been seeing. And these increases have occurred in parallel with increasing prevalence of both vascular risk factors, which are happening at younger ages, and also there's some substance abuse as well that's been increasing. And I added this slide just to show some characteristics for stroke in the young. The sex distribution is different, as well as the risk factors. So women do predominate in the youngest age groups, and it shifts to men over the age of 45. And then as we get into older age groups, it coincides with the rise in more of the risk factors that we traditionally think of with stroke. Medicine is getting much better at treating acute stroke, and the survival rates are better, which is wonderful. But the flip side of that is that many people have ongoing effects from their stroke. It is the leading cause of adult neurological disability, and our younger adults with stroke will be living likely a long time with these effects. When we think about the consequences of stroke, we think about motor and sensory. Those are the obvious ones. We can see aphasia or language problems, and we see cognitive problems. What we also see are emotional disturbances, and those are frequently overlooked. Not a lot of people think of that as being a consequence of stroke, and it is what we're going to focus on today. This is a review study that broke down the frequency of post-stroke neuropsychiatric disorders. So you take it with a grain of salt, because depending on the studies that are done, rates may be quite a bit higher than this, depending on the population and the methodologies used. So depression is the highest, and in all studies, kind of the meta-analyses, it's about 35% of the stroke population. Anxiety is also quite high at 25%. Emotionality, apathy, catastrophic reaction are all about 20%. Delirium is common post-stroke, much more important for the inpatient population and the rehab population. Vascular dementia is significant. We're not going to be taught that's out of the scope of this presentation today. Mania and psychosis are rare. They're not really associated with post-stroke. And I just added the PTSD piece because that was not identified in this particular study. It is not well studied either, but I do think it has been cited to be occurring in up to 25% of the population post-stroke. And I certainly think it's more so in younger patients. And so I do get asked this question, like, what is your typical post-stroke patient, or what is your typical younger post-stroke patient? So I wanted to take a few minutes just to review some patient snapshots with some of my patients. So this is a 48-year-old married female who had a pretty high-level career in tech sales. She had a history of generalized anxiety disorder longstanding, which was treated by her family doctor and well managed. She had a past medical history of a few vascular risks, had a stroke, and had post-stroke cognitive issues. They were mild, but they were broad, so they affected many areas of her processing. She ended up with severe post-stroke anxiety and depression. She definitely had PTSD symptoms from her stroke, and she required actually a couple of inpatient hospitalizations until she was stabilized. I followed her for quite a while. She's never been able to return to work. She has a lot of difficulty doing tech now, which was second nature to her. So she can do a few things on her phone, but that's it. Like, she can't do any more of the regular things or paying bills or things on a computer. And that is a trigger for anxiety for her. Being unable to return to work has caused a lot of financial stress and also a loss of her independence financially. This woman was incredibly career and achievement focused. She obtained advanced degrees in university, and being unable to work and being financially dependent has continued to be a very challenging issue for her. This next case is a 42-year-old married male. He had a career in the legal system, history of mild anxiety like so many people do, untreated and very manageable. No medical history. It wasn't until his second stroke that a vascular abnormality was discovered. But he came to me after his first stroke. And by 3 months after his first stroke, his physical issues had resolved. And so in fact, everyone just looked at him as being better because he seemed to be doing physically so well. But emotionally, he was dreading his future. He was worried about more strokes, which it turned out to be a real worry, an actual worry for him because it happened. He was concerned about how he'd be able to function in his career and how he would be able to provide for his young family. And he came with a lot of anxiety, new panic attacks, which ended up leading to depressive symptoms, a sense of hopelessness and worthlessness. And he actually presented with active suicidal ideation and a plan to kill himself, clearly. So he was very important to have been flagged and sent to care. This next case is of a 39-year-old married male, business executive, no medical or psychiatric history, and he had a stroke due to carotid artery dissection. He did not have depression or anxiety, but he had a lot of emotionality. He was crying very easily, and he was not a crier. It was very unlike him, very uncomfortable. He also found himself to be irritable, yelling at his kids, short-tempered with his wife, and also feeling very edgy at work. And this led to social isolation. And I remember when he came to me and told me about one specific incident that really caused him to withdraw. And it was that he went to watch the World Cup with his friends at a bar. And it was something they did every time the World Cup came on. And he went to this game and he cried like for so much of the game, anything emotional, whether it was exciting, whether it was disappointment, he would burst out in tears. And he was horribly embarrassed and basically said he doesn't want to see his friends anymore. He can't be in front of them like that as a man. And he really withdrew socially. Just a couple more cases here. So this is a case of a 34-year-old married female entrepreneur, no history from psychiatry or medical history. And her stroke occurred 1 week postpartum following a chiropractic neck manipulation. She presented to me with post-stroke depression and panic attacks. And she also had post-stroke pain syndrome, which every time she started getting neck pain or a headache, it triggered panic and fear that she was having another stroke. She, as a result, withdrew from her kind of the mom life and her work as well. So for her, she could engage with her baby and her toddler, but she really strongly felt alone, that none of the moms could understand her or what she had been going through. So she felt very disconnected from the typical mom social scene that would normally provide a lot of support and community for a young mom with 2 little kids. Another worry for her was that would her husband want to stay with her long term? Because previously to her, before her stroke, she saw herself as like a beautiful, young, healthy, dynamic woman. And now she had these issues related to stroke and wondered how her wonderful husband would be able to stick with her long term. This is the last snapshot. 28-year-old single female. She was a high-level athlete. She used marijuana, mostly for pain, but also recreational. And she had a hemorrhagic stroke. She presented with post-stroke depression and anxiety. She had post-stroke fatigue and no motivation. She started using more marijuana to cope emotionally and had passive suicidal ideation. Part of the thing for her was whether she would ever be able to return to her athletics career, which was her full-time job and very much her identity. So that caused a lot of anxiety and despair. It was the source of her self-esteem, and her whole social circle was involved in her athletics. Her female partner was also an athlete and started distancing herself. So this caused a fear that she was going to lose this relationship, and also kind of looking to the future, that would she ever find a partner who would take her now that she had, this potentially ruined career and illness. And so
Dr. Tennant,
yes.
There was just one question just about the cases. Did any of these individuals have aphasia?
None of these particular individuals had aphasia, and notably, physically, they all had quite good recovery. So even though they were not very debilitated, no one was wheelchair bound, everyone was quite physically able. Emotionally, they were not able to function because of the emotional consequences. And so the themes that came up really that some of these patients have in common, but also frequently come up in young, I think more than old, is, well, I think the fear of having another stroke is universal. At any age, that's a fear. Fears of being debilitated and dying, also a fear for everyone, I think, for most people after stroke at any age. But I think for young people, the fear of being debilitated or wheelchair bound or dying young is, or with young children, is especially challenging and hard to deal with. Also, their careers were affected at the prime of their lives when they would normally be expanding and building, and it was interrupted suddenly. They had financial worries because, the younger they are, usually the less of a financial cushion they have. What is a big theme is that they feel alone, like nobody understands them, because how many 30-year-olds in their social circle, or even 40-year-olds, and sometimes even 50-year-olds, look around and know people in their social circle who've had stroke, or can look and say, oh, my husband had that, or my sister had that. When people are 75 and 80, they've seen people with stroke. People understand what that is, but younger patients feel very misunderstood. Also, if in these snapshots, for people that have a good physical recovery, then it becomes an invisible issue that nobody actually is even aware of what they've been through, this traumatic experience usually. And also if they're struggling with cognitive or emotional issues, it's unseen to people. So they really don't get support the way that other people might. Their relationships can be affected, and there's uncertainty about what kind of relationship they'll have in the future. And also they often have social isolation and withdrawal. So basically, there is no typical patient in a stroke psychiatry clinic. The issues after stroke are quite varied and colorful. This is a study that came from my colleagues at Sunnybrook that compared younger and older stroke patients in terms of the frequency of anxiety and depressive symptoms. And so the younger age group in this study was defined as 18 to 50-year-olds. And if you look at the results, I just want to highlight that the younger patients were more likely to have elevated screening scores. So the way they detected the symptoms was by screening. And then if you look at the anxiety and depression together, it was almost 3 times more likely to be experienced in younger patients than older patients. If we think about onset of depression, anxiety as well, it usually peaks around 3 months to 6 months. But the interesting thing is that the risk remains long-term. So in this particular study, it was still a 29% prevalence of major depression in stroke patients at different follow-up periods. The depression and anxiety risk can persist for many years. There's an anxiety study that came out that showed the risk is prevalent even at 10 years. And that just resonated with me when I saw that, because I recently assessed a 50-year-old woman who had her stroke in 2012, so 10 years ago. And she clearly was well psychiatrically, had nothing prior to her stroke, but had a post-stroke depression early on, and it has remained all these years. So she came to me from her new stroke neurologist with ongoing despair, passive suicidal ideation, and she's really been struggling with this for a decade. It all clearly started after her stroke. And she saw one psychiatrist who did a brief consult. Unfortunately, she was nervous about trying medication, and she didn't get a lot of education about it. She was given a prescription and a follow-up 3 months later. And when she didn't like the way she felt early on in taking the medicine, she stopped it, and then she didn't engage in the treatment after that. So unfortunately, that was like a missed opportunity for her. So we're getting her on track now. Post-stroke depression has been studied a lot, and different risk factors have been highlighted. And it's a little bit controversial because it depends on how the studies were done and what the literature points out. It depends on the studies. But one thing that seems to be clear is the severity of functional dependence usually comes up as a consistent risk factor. Having a psychiatric history or depending on the medical history could also be risk factors. Social isolation is a consistent risk factor, and genetics also in terms of family history of anxiety or depression and other psychiatric issues can also predispose people to developing depression post-stroke. There's been some studies that look at maybe female sex could be a risk factor, specific age groups, younger age groups, under 70, under 65 or younger, maybe risk factors, and then also the characteristics of the stroke and lesion location have been cited as possible factors. So just looking at the causes, one is we always want to try to figure out why things happen. So there's a biological theory, which is that the injury in the brain affects mood regulation. There's been studies on inflammation and lesion location that suggest this, and depression sometimes occurs after stroke more than certain other illnesses that has been shown. And it can occur even in silent stroke. And this is just an illustration of a study that was done at Sunnybrook, looking at lesion location. So basically, they map where the stroke lesion is and then compare if those patients are more depressed than others. And left hemisphere is associated kind of classically with post-stroke depression in hospital inpatient studies, but really it hasn't totally been replicated to be sure. So it's like a possibility. We don't know for sure. The other theory is psychosocial. That makes sense. People have gone through a major shocking life and death event, and the depression is a reaction to that. Depression in post-stroke looks just like any other depression. There are risk factors unrelated to the stroke. And then, as I said, the biological mechanisms haven't been consistently replicated. And this is just a model of how illness can sometimes lead to depression. There's kind of normative responses of anxiety and sadness and maybe distress. But then depending on what else feeds into that, are they, past history, genetic loading, how they cope, what kind of medical complications they have, and what kind of social supports they have, are some of the things that they have found that could lead to depressive disorders. I want to point out that depression, both major and minor, have been found to impact recovery. So not only is it associated with social withdrawal and a worsened quality of life for the patient, for the family, it's associated with increased caregiver burden, but it is also associated, there have been studies to show poor rehabilitation outcomes, a worsened cognitive recovery, as well as increased mortality. I just want to spend a second on increased mortality. Why would that be? So there may be direct biological effects, but then also it's other effects. So for example, when people are discharged from hospital post-stroke, they often are on new medications, sometimes several. It's hard to get used to that. And people who are depressed will have a harder time adhering to those new medication regimens. There are often recommendations to modify their lifestyles and engage in healthy habits, exercise and changing their diet. And it's very difficult to do that for anybody post-stroke. It's even more difficult for people with depression. And then, of course, it's hard to quit smoking and hard to cut down on substances at any time. But certainly with depression, sometimes it's the substances and smoking that are helping them cope. So it's even more difficult to get into those healthy preventative habits. Post-stroke depression also comes with challenges in diagnosis. It takes time to diagnose someone with depression. It's really hard to do that, especially now the medical system is so stretched, but you can't rush the assessment. Oftentimes people may have communication difficulties or aphasia, they may have cognitive impairment, they may have a lack of insight or awareness into their depression. And then depression can also overlap with medical illness. For example, the criteria for sleep, energy, appetite, concentration, that could be because of medical issues and not just depression, and also overlaps with other syndromes, which we'll touch upon. And then we can't underestimate stigma because it still very much exists. People oftentimes don't want to seek help. They don't like seeing a psychiatrist. They can often see depression or anxiety as a personal weakness or flaw that they should just be able to get over, or that may be the feedback from people around them. So stigma is still a barrier. I just want to read this quote. These are two CL psychiatrists from Harvard, and this quote was from 2003, but I think it is just as relevant today. And they say, despite the devastating consequences of untreated post-stroke depression, it is vastly undertreated. Early and effective treatment of depression is perhaps even more crucial in this patient population, given the need for full mobilization, for occupational and physical therapy, and other functional retraining early in the course of recovery. And so the way to detect it is to recognize it and ask about it. So this is one of the screening instruments that's often used. It's the PHQ-9, and it just reviews the diagnostic criteria for a major depressive episode. So it's a good example of how we diagnose major depression as well, and you can see the screening instrument. There's also a PHQ-2, which is a short version. And in fact, there's validity to just asking, do you think you're depressed or are you depressed? And so there's no clear guidelines regarding timing. You'll see different things in literature, but just ask and you'll be able to detect quite a bit of depression as well as anxiety post-stroke. And so we're going to focus case coming up on depression. We'll do a shorter one on anxiety. We're also going to talk about treatment considerations. And I just show how this overlaps other issues that are a little less common but can still occur. It's important to differentiate between them. This is a post-stroke depression case of a 34-year-old single female, no psychiatric history, no past medical history. PFO was discovered after her stroke. She had a left end-phase stroke and was left very affected. She had right-sided weakness. She had a seizure. She had seizures after. She had pain, and she also had expressive aphasia. So she could speak, but it was very challenging. Certainly, the more tired and more stressed she was, the more her speech abilities declined. And so they screened in the stroke neurology clinic at Sunnybrook and referred her for urgent assessment. She was hopeless and was not able to engage in rehab. And so this is how she presented: depressed, couldn't enjoy anything, very tearful, poor sleep and appetite, energy and concentration. She felt worthless, hopeless, basically screened positive on every single criteria. And she wanted to die. She just said, it's too much, I need help. And the losses that she spoke about highlight some of the things we already talked about in young patients. So she was in the prime of her life. Her friends were busy. They were active with work. They had social lives. They went out a lot. This is pre-COVID. They had children. She was advancing her career. She was building many aspects of her life. And then she was left feeling no longer independent. She lost her job. She lost her financial security as a result. She had to move out of her townhouse with stairs into an apartment. In fact, her family was pushing for her to go into long-term care. She became very distant from her friends, and her two main hobbies were dancing and cooking, and she couldn't do it anymore. And so in terms of treatment, these were the first steps. Access and education, optimizing her medical conditions and things that could be contributing to her mood, and liaising with members of the team. And so what we did is I provided a lot of education around mood changes after stroke, so that, again, it wasn't a flaw in her that she was feeling this way. We made regular appointments at the beginning. I saw her once weekly, and we also, my office kindly helped her to arrange Wheel-Trans so she could get to us regularly. With optimizing her medical conditions, we did blood work, checking B12, TSH, and ferritin, which all can contribute to fatigue, lack of concentration, and low mood. And also her blood pressure was running high, so we asked her family doctor to follow that more closely. And then I liaised with the neurologist and the other members of the team. So she was placed on Keppra, which is an anti-seizure medication that is known to potentially induce depression or worsen mood. So we worked together about possibly changing that. And then the neurologist was saying that they were considering trying to duloxetine, which is symbolic for pain. And so that helped guide the medication that we chose for her depression treatment. And so when she came to me through inpatient and rehab, she'd already been tried on some medicine. Mirtazapine 30 milligrams actually made her very restless, and paroxetine made her very nauseous. So she didn't tolerate those. And so again, lots of education around medication. We opted to start the duloxetine 30 milligrams, went up to 60 milligrams where she had a nice response. And the neurology increased it to 90 milligrams later for better pain control. And at the beginning, I thought she was going to need more than one medicine, but in fact, it wasn't needed. So I just want to talk a little bit about medications in general for post-stroke depression. So SSRIs are generally considered safe and well tolerated. The common side effects do tend to resolve over time. There are rare but serious side effects that you need to be aware of. So carries a risk of bleeding, a very rare risk of seizures, more at high doses. It can induce mania if they have an underlying bipolar disorder or suicidal ideation, particularly if they don't tolerate it and are given high doses off the bat. There's the risk of QT prolongation, and that is more with citalopram and escitalopram. Any SSRI or SNRI can induce hyponatremia, and it's idiosyncratic, so I check for that. Serotonin syndrome is also a dangerous risk, not common, but if they're on any other serotonergic medications, it becomes a higher risk. And falls, which is more frequent in an older population, but still occurs across the spectrum. Just to be aware of medication interactions, most antidepressants do inhibit at least one of the metabolic pathways in the cytochrome P450 system. And so citalopram, escitalopram, and sertraline are better for that. Fluoxetine, paroxetine, most people don't use fluoxetine anymore, but those, Prozac and Paxil have the highest risk of interaction. And although we don't see a lot of patients taking warfarin anymore, you need to know that any of these medicines can interact with warfarin and change the INR. And so you have to manage it carefully. So when you start an SSRI or any of these medicines, and SNRI as well, if you change the dose or you stop it, you need to be monitoring the INR more closely, or ask whoever is monitoring the INR to monitor it more closely. Considerations when prescribing also includes what the patient wants. So what do they want? What are they going to stick with? What have they had in the past? What are the side effects that might suit them? For example, mirtazapine can increase appetite and be sedating. And that can be helpful to someone who's anxious and can't sleep and can't eat because they're too anxious. And also consider drug interactions. I want to mention for those of you that will be prescribing medication that you can look at the Canadian Stroke Best Practices recommendations. They have one on mood, cognition, and fatigue following stroke that was updated in 2019. And they have a summary table for medication for post-stroke depression, and it's a really good reference guide. So I would suggest you look at that. And so then we also did lots of supportive problem solving and CBT strategies outside of medication, focusing on the issues that she was struggling with emotionally. In addition to medication and therapy, we did added strategies, everything from mindfulness and sleep hygiene to quitting smoking, finding meaningful activity. She was able to start in rehab, and her mood was much improved with treatment. Though she was unable to go back to work, she found great satisfaction in volunteering and also did some stroke peer support, which was lovely for her. And so just to summarize post-stroke depression before we move on into a few other areas, just to note, depression is common after stroke. Detection and diagnosis can be challenging, but it's really important for so many reasons. Untreated depression can become chronic if the risk doesn't magically disappear. It can worsen functional outcome and impact survival, including, in addition to the quality of life factors. I encourage you to use a biopsychosocial approach to treatment, and medications are safe, but they do need to be monitored. And so just going back to this slide, we're going to move on to a shorter anxiety case, which is the other pretty common category that we see post-stroke, and then just very briefly touch upon the other issues.
Dr. Tennant, just before, there's just one question in the chat that relates to this slide. So if you're okay, just to answer, what does catastrophic reaction refer to?
I'm going to talk about that. So you'll see it coming up. I do have a slide on that. And so it's not depression, it's not anxiety, but when it happens, it's just like an outburst. So it's an emotional outburst that people end up thinking like, oh, well, they must be depressed if they're acting that way.
Thank you.
So we'll touch on that. Okay, thanks. So post-stroke anxiety, also common, as I said, about 25%. And the thing to note is it's very often comorbid with post-stroke depression. It also negatively influences recovery and function. And comorbid GAD, which is generalized anxiety disorder, prolongs post-stroke depression. And GAD, generalized anxiety, is usually used in the study, and it usually, for non-stroke patients, has a 6-month duration criteria, which is usually dismissed for the post-stroke studies. And so anxiety, I think everyone has experienced anxiety to some degree, extreme apprehension, tension, worry, but this is to a high degree without necessarily clear triggers. It can be just overbearingly uncomfortable. It can occur with or without depression, but it usually coexists with depression, as we talked about. And we do treat it also with all the things that we talked about in the depression case, the medication as well as psychotherapy. And so the quote that I have here is of the patient that's coming up in a minute is, I can't do an MRI. What if something happens to me while I'm in there? In other words, he was worried that he was going to have a stroke. And so this case is of a 41-year-old married male dentist, no psych history, no medical history, no vascular risk. He was a lifelong worrier and perfectionist, but very high functioning, didn't cause a problem for him. And after his stroke, he refused an MRI and other investigations. He was too anxious about it, and that's when he came to neurology sensitivity. And so he said himself, I'm freaking out. He had waves of panic all day, poor sleep, poor appetite, was losing quite a bit of weight and started worrying about that, and poor concentration. So not only was he anxious about having another stroke, but he became anxious about being anxious. So we do see that people worry about how much they're worrying. And for him, it was often a physical anxiety, worried about his physical health. So what if my blood pressure goes up and I have another stroke when I'm sitting here so stressed and anxious? He was very debilitated by this. He was unable to be left alone. He was unable to go to work, and he was too anxious to see his friends or support. So he came on me on what we call Z drugs. So he was on zolpidem to help him sleep, and quite a bit of lorazepam at a good dose. That's a pretty hefty dose. He was doing it at least twice daily. That actually ended up putting him on a roller coaster of anxiety and sedation. So he would wake up super anxious. He'd take lorazepam. He'd be calmer and then sleepy for a while. He'd nap or kind of chill out, and then he would kind of wake up or be struck again by panic and go into a big panic again in the afternoon, and then eventually take the lorazepam again and then calm down again. So he really was up and down all day. And so the treatment that we worked on together was just support and strategies regarding his fears so that he could start taking medications, different medications, and do the stroke investigations. He initially requested escitalopram because his wife was on it, but he didn't tolerate it. So we ended up trying him on sertraline, gently, very gently, went up to 150 milligrams a day. He could go on that. We added melatonin for sleep, and eventually we got him off the lorazepam as well as the zolpidem. Other things for him is that he did cognitive behavioral therapy, went to couples therapy, started the healthy things like exercise to burn off some anxiety, relaxation exercises, sleep hygiene. Eventually, as he got a little better, started doing joyful activities. And though I didn't prescribe it, he got a dog, and that ended up being extremely therapeutic for him. He got out for walks. He started talking to people in the park, at the dog park, and he had this comfortable little companion all day long. So that really helped him. His anxiety got much better. He was able to return to work, and he chose to go about 4 days a week, most weeks, to be able to limit his stress. Down the road, he was able to taper off all of his medications within 2 years. He was very high functioning. His marriage did not withstand the pressures that the stroke and anxiety brought. He did end up being divorced. And periodically over the years, he's returned to treatment for reoccurrence, which has really just happened when he has a new medical issue. And that's a trigger for him. So now we're going to just touch upon, we're just almost finishing up here. We're just going to touch upon those few other things to be aware of when you're thinking, is this depression mainly? Sometimes is it anxiety, but more is this depression. So one is pathological affect. It's not the best name. It's been called pathological laughing and crying, emotionality. I tend to use the word emotionality. It's also been called emotional incontinence, emotional lability, as well as pseudobulbar affect. You see that quite a bit in the literature as well. And this is usually tearfulness. It can be crying or laughter, but much more common to be crying. And it's severe, persistent, or troublesome crying, tearfulness. It is exaggerated from their underlying emotion. It feels uncontrollable. And also what you'll often see is that people will burst into tears quite suddenly or cry a lot, and it may dry up pretty quickly. So there's a feeling that it's not like a depth of sadness that is hard to stop. It can be quite on and off. And one of my patients with this said, I know my face looks sad, but I'm not feeling sad at all. But they were crying. And so it's important to ask about and think about the characterization of these episodes. What are the precipitants or triggers of these episodes? And really importantly, what is the associated emotion? So there are lots of people who say like, yeah, I feel a little sad, but like I would never normally cry like this just because I feel this sad. Or they'll see a sentimental ad on TV that maybe would have choked them up a tiny bit, but now they're bawling. It's just way in excess and it feels uncontrollable, and it can cause a lot of problems for them, like that patient snapshot who went to go watch soccer with his friends. It was just a really challenging experience for him. The next thing I'll highlight is apathy. So apathy, frequently people mistake it for depression because patients present with a loss of motivation, a loss of interest, and sometimes they're not particularly concerned, and they can sometimes have a loss of emotional response. The important thing is that apathy doesn't respond to SSRIs. So it is a different kind of treatment. Instead, we use the dopaminergic medicines like bupropion or methylphenidate, which is Ritalin. It's also hard to treat in general. And a wife of his husband, a husband who came to see me, this was her quote: "If I let him, he would just sit in his chair all day doing nothing and he'd be perfectly content." And so that's the difference. Someone who's depressed and sitting on a chair all day is not content. They are depressed. They are unhappy. And people who are apathetic generally do not express a subjective sense of being down or not being able to experience joy. Oops. And there's the catastrophic reaction that someone asked about. So these are outbursts when people are unable to perform simple tasks. It can look like anxiety, aggression, anger, and they may refuse to do things. It's a lot more common in patients with expressive aphasia as the frustration is building up, and also in patients with cognitive impairment. And so a typical scenario that I can think of is a couple where a previously very independent, strong man who post-stroke is struggling to tie his shoes. And also he has aphasia, so he can't just fluently, easily tell her what's going on, but he's working on tying his shoes and his wife comes up and says, "Hurry up, we're gonna be late." And he'll just have a big outburst. And the same patient was ironing his pants for the first time after stroke. And for him, that was a big deal to try to do that. And his wife came up and started instructing how to do better. And he just kind of roared and really reacted much more strongly than you'd expect. And clinically, sometimes we see this like in patients if you're going in to do some kind of examination or cognitive testing, and they start getting frustrated because they realize they're not doing well, and then they might have a big outburst. So people will sometimes say like, "Oh, they must be so anxious," or "Oh, they must be so depressed because they're so irritable." But again, subjectively, they don't experience that. It's just in these moments they're really triggered. And so the management is not medication. The management is to really study the triggers, look at prevention, how to avoid the triggers, and support the patient through what's going on. Be calm when you're approaching them and explain what you're doing. And also, we're always watchful for comorbid depression. I just want to close by mentioning delirium. So this is quote unquote the great imitator. It can look like anything, and it's much more important in the inpatient or rehab population, but can still occur in the outpatient population. And I've certainly seen it. It's also more often in older patients, but in the setting of medical illness and patients with vulnerable brains, it can occur at younger ages as well. So most people are familiar with what we call hyperactive delirium, which is when patients are agitated, they may be hallucinating. These are the patients that in the bed are climbing out of bed or pulling up their lines or being paranoid that something's happening. But there's also hypoactive delirium, which is very easily missed. These patients are quiet. They don't cause any trouble. They're sleeping a lot. They're lethargic. They're not really motivated. They don't engage in rehab well. And this can look like depression. So frequently people can come flagged for depression, or you'll see them and you think they must be depressed, but really it's still hypoactive delirium. So the thing about delirium that's important is you want to attend to it first before we can diagnose or treat depression. And you want to go actively investigating for underlying medical problems or things that could be contributing to why this is happening. So now we're wrapping up. So these are the take-home points for stroke in the young. The incidence of stroke in the young is increasing. Younger patients often have different challenges than older patients, but the situation can be challenging for anyone, of course. Depression and anxiety are common after stroke, and they really should be screened for. Comprehensive treatment can improve outcome and quality of life. And it's important to distinguish overlapping neuropsychiatric syndromes in order to guide your treatment. And thank you so much. That is the end of the presentation, and I'm happy to take questions.
Thank you so much, Dr. Tennant. So much important information shared with all of our attendees today on not only recognition, epidemiology, and understanding of this very important topic, but also opportunities for assessment and treatment and things that can be brought into practice very pragmatically. So thank you for such a wonderful presentation. I ask the audience, please put your questions into the question and answer box. We were able to respond to a couple of questions through the presentation, but please, and the other option is as well you can raise your hand and we can allow you to ask your question live to Dr. Tenon. Maybe I can start off with a quick question, Dr. Tenon, as we wait for some of the questions to come into the question and answer box. But I wonder, and I think you touched on it briefly in your presentation, I wonder if you feel, if you have a sense or a feeling of this trend for the future. Is this a topic, a challenge, an issue that you feel will increase significantly as we move forward in the next number of years? And in particular, as you broke down the different components of what this might look like in terms of whether it be depression, anxiety, catastrophic reaction, et cetera, are there certain particular aspects that you're seeing increasing more than others?
Great question. I do think with the incidence of stroke increasing, this issue is going to increase. And I can say I've been doing this now in practice for 15 years, which is quite shocking when I actually say it because I feel like I'm still a youngster. But no, I don't think that it's still been adequately addressed over this time. And so I just think that as more people, I think, are being more, hopefully the stigma is decreasing a little bit. There's more dialogue about mental health and psychiatry. People may be becoming more open to considering these things. I do think that both with more stroke patients and more openness and awareness of how they can be impacted emotionally, I think this will become even more important, or at least more, hopefully more attended to. And I do still think, especially in the young patients, well, depression, anxiety is high across the board. It really is. And so those are the things that we always want to keep a lookout for.
Dr. Tenon, there's also a question or a comment in the chat. Isolation is listed as a risk factor for depression. How has the pandemic and isolated affected the incidence of depression, the severity of, and recovery, treatment recovery?
I think that's an excellent question. I don't have any literature on that, but I think that your point is well taken that so many people have been so much more isolated through the pandemic. I also think that unfortunately, a lot of the services that people would have been able to access pre-COVID have been very difficult to access. So there are longer waits for everything. There are longer waits for rehab. In Toronto, we have the Aphasia Institute and some other things that people would go to. And not only would they get their experience there or their group or their treatment, but they'd also get social connection. And sitting in your living room or your office at home, doing it by Zoom is not the same. And so I do think that for many reasons, it has been more isolating, and accessing both treatments and social connection has been more difficult. So I would imagine that, and I've seen, it makes things harder for people. I have a 50-year-old stroke patient who initially had a stroke at age 45, and he has very significant expressive aphasia that he is like raring to go. He's a lot to offer. He wanted to volunteer for the longest time, and only now, it took him all through COVID to get started at a volunteer position at Sunnybrook. But he would have loved to have done this 2.5 years ago. He was ready. And so I can see how it slows people's progress for sure, any kind of isolation.
Thanks, Dr. Tenon. A few questions have come through Q&A, so maybe I can get started on those, and we'll make sure we end on time. But the first question is, what is your recommendation for managing behavior in a person with a history of borderline personality?
Yeah, so, I mean, I don't have any expertise in borderline personality disorder, and I think that it would be very much along the guidelines of both medication and non-pharmacological treatments for that disorder. I don't think that it would be anything specific post-stroke that would change the treatment. Unfortunately, I don't have any kind of pros for that.
Thank you very much for that. The next question is, what aphasia-friendly depression screenings do you recommend for younger individuals post-stroke? This audience member has used the PHQ-2, but found the wording is very challenging for people with aphasia, which is the population that she works with.
That's a really excellent question. So sometimes we use pictures. So like a picture of a sad face and a happy face, an angry face, and just like thumbs up, thumbs down, is this how you're feeling? And also just even simplifying it even more to just ask that question, are you depressed or do you think you're depressed? I know we always want to use the validated screening instruments, but we definitely have to get creative in certain cases. So that's what I would do.
Wonderful. A couple more questions here, Dr. Keenan. One is, do you accept external referrals at Sunnybrook, or do you know of any other psychiatry clinics with similar expertise?
So right now, my referrals are mainly inside Sunnybrook with the stroke neurology service. And the way people usually access psychiatry who specialize in stroke are at the rehab facilities. So most rehab facilities have some kind of psychiatric service, at least in Toronto. There's some kind of service associated with that, and they get linked with them. Unfortunately, my understanding is they don't follow them ongoing. So sometimes they get to me through that, like St. John's Rehab is associated with Sunnybrook, so we can get referrals from there. But oftentimes it's just important that they get some good recommendations to get them on the right foot. And then usually the family doctor can pick it up from there.
Fantastic. Thank you, Dr. Tannen. One last question here before we'll wrap up. In your experience, do most people with post-stroke depression require a course of meds as part of their treatment plan? How do you deal with resistance in this group?
That's an excellent question. First thing I want to say is that most people with post-stroke depression get better. I want to point that out with treatment. It can become incredibly chronic without treatment. So they really need treatment. And what I would say is, in truth, I do think most of them need medication. I do think medication really helps, but I definitely have encountered that resistance as well. And in that case, I just try to meet the patient where they're at. And I try to engage them in everything else I can think of that could be helpful, aside from medication. And then hopefully over time, the therapeutic alliance is built really strong. And if they are not better after trying all of the non-pharmacological suggestions and they're still really struggling, it gives more of an invitation to have an ongoing conversation about medication. And I will do that. Like, I will say, like, I totally respect where you're at, but I'm going to have this, like, I'm going to bring this up occasionally just to let you know that it's still on the table, it's still on my table for suggestions for how I can help you. And usually they're quite open to that. When they feel like you're partnering with them and you really have their best interests at heart and you're really trying to hear and validate where they're at, then they can sometimes become more open-minded to trying medication.
Fantastic. Thank you so much, Dr. Tannen. I think we'll hold there. We'll hold there and maybe wrap up today's webinar. Greatly appreciate. Oh, sorry, Rhonda, go ahead.
I was just going to say there was just a response to that initial question that was saying, thanks. I agree. That's what I'm doing with one individual. He has had active suicidal ideations, but won't take meds.
Yeah, I would just keep working and working and working. And then at some point, you know, just be very, very transparent. Like, when we're dealing with suicidal ideation, that kind of trumps everything. That is a huge risk. And how long do we wait to have you be at high risk without treating? And so really just trying to figure out ways to get in and move him forward if possible.
Perfect. Thank you so much, Dr. Tannen. Again, we greatly appreciate you taking the time today and talking to all of us on such an important topic. We really appreciate your time. This was incredibly helpful for all of us attending. So thank you very much. And I would like to turn to the audience and let everyone know, again, you'll be getting an opportunity to provide feedback on today's session through email. We do encourage you to fill that out, as it really does help us shape our future education sessions for the Central South region in order to get the most benefit from these this webinar series and webinar series in the future. I do want to remind everyone if you are interested, please register for our next part in our webinar series. I'm just posting it to the chat. You can actually hit that link and register at that site. The next part in our series on stroke in the young is focusing on community reintegration post-stroke. And this will be a panel of presenters, including Drs. Michelle Nelson, Dr. Averand, and Dr. Gopal, who will be speaking to us about that topic. And that will be on December the 8th from 12 until 1. Again, another sort of lunch and learn session. So I thank you, Dr. Tennant. I thank all of our attendees today. What an excellent talk today, and such an important topic for us all to become further educated on. So thank you, everybody. I hope you have a wonderful day.
Thanks so much for the opportunity. Appreciate it.